Welcome to today's webinar. The webinar is Implementing the Frailty Portal in Community Primary Care Practice, Evaluating Feasibility, Effects, and Expansion Needs. I just want to take an opportunity to go through a few things before we start today's presentation. There will be a Q&A session after their presentation, which will be likely around 25 minutes. If you could submit your questions online during the presentation, and we'll try to get to as many as possible. If we don't get to them, we will have an opportunity to email the presenters and hopefully get an answer back to you. At the end of this webinar, a survey will pop up on your screen, and we are looking for your feedback to improve webinars as usual. The webinar slides, I'll just go to the next session. You'll see that the webinar slides are going to be up within 48 hours, and there is the link to our website. Just to review a few webinars that are coming up, we do have hopefully someone presenting in May, but they've canceled, so we'll put somebody up in the next couple of weeks, or we'll put their presentation webinar time up in the next month, or maybe in the next week, I guess, if it's May. So on July 12th, we have Paul Stoley and Jacoby Elliott doing the Implementing a Risk Screening Tool in Primary Care for Older Frail Adults. And on July 26th, we'll have the IGAP with Michelle Howard from McMaster University. Just to let everyone know, I know we've already received some letters of intent, but we launched the CFN Interdisciplinary Fellowship Program on Friday, and the intent to apply is May 15th. This will be the first time that we are doing an online competition or an online application process, so it may take a little bit longer this year to get it up and running, but if you go to the website here, you will see what the process is for this year and get more details. And if you have any questions, there is an email to ask your questions, and please don't hesitate to use that, as it will be the first ever application online. Even in terms of research in this past year, we haven't done an online application. So this is kind of the guinea pig process. Now, just to have an introduction, we are having 3 presenters today, and they are at various locations. So each person will be changing slides as we go through. So the first presenter will be Paige Morehouse. She's the Associate Professor, Geriatrics and Internal Medicine at Dell. Sorry, I'm just moving my cursor here. And she's the co-chair of the Frailty Strategy for the Nova Scotia Health Authority. We also have Tara Sampali. She's the Director of Research and Innovation in Primary Healthcare and Chronic Disease Management at Nova Scotia Health Authority. She's the Assistant Professor of Medical Informatics at Dell University, and she is presenting from the US today. And we also have Ashley Harnish with us today. She's the Health Services Manager at Nova Scotia Health Authority, has clinical experience working in community palliative care, geriatric assessment and rehabilitation unit, and acute care. So please start, Paige, and thank you for agreeing to present after you presented this weekend at our conference.
Thank you, Carol. Hopefully you can hear me and also see the slide, the title slide for the presentation. And hello also to Ashley and Tara, who are spread across the continent as we speak. All right. As I think probably all of the attendees for this webinar are already aware, we're having an increasing challenge in terms of the resources and costs associated with caring for a relatively small proportion of the population who is frail. And I think in Nova Scotia, where we have the oldest population in Canada, that is perhaps particularly relevant. So the estimated prevalence of frailty amongst Nova Scotian seniors is about 32%, and that is only an estimate because we don't have a measurement of frailty in some of the larger scale provincial data sets. But the estimates are that 55,000 of those are in the central zone of the Nova Scotia Health Authority, and we already know that the spending on these individuals is considerably higher than it is for those under the age of 65, but unfortunately we haven't seen that that increased spending has resulted in an improved experience of care or improved outcomes for that population. And most of that spending is in the last 6 months of life. So just to make sure that we're all speaking the same language as we begin the webinar today, I thought we'd take a brief step back to describe the term of frailty to begin with. I think one of the challenges with this term is that it already exists in the public domain, and every person in the public domain has their own, idea of what frailty is. And currently I think we're in the process of reappropriating that in the medical community, but we have a lot of work to do in terms of getting the messaging consistent even amongst ourselves. So for the purposes of this presentation, the working understanding of frailty that we use conceptually is that as we go through the life course, we tend to accumulate health issues. Some of those are acute and some are chronic, but each of those has an impact on a rather finite amount of physiologic reserve that we have in order to withstand and recover from each of those episodes. And so when that accumulation of the health issues over the life course, and those could be medical or social issues, when that starts to impact on a person's baseline day-to-day function, their cognition or their mobility, this is what we mean when we refer to frailty. And why should we care about frailty? Well, probably everyone that's tuned in today already cares about frailty, but certainly the research would say that it's emerging as the single most important prognostic factor across health systems, across patient populations, across interventions, to really inform us as to how an individual patient can expect to fare with various standard of care interventions. And in a related way, it tells us who should perhaps avoid risky standard of care interventions in favor of care that's more focused on comfort than cure. Frailty tells us what to expect in the future and can inform care planning and how we communicate with patients and families. And we have lots of data to show that it can be reliably and easily measured in various areas of care. One of the challenges with frailty, which I spoke to at the conference recently on the weekend, is that there are multiple tools to measure it, and certainly the research has borne out that regardless of how you measure it, the prognostic significance remains. But I think as part of the frailty strategy in Nova Scotia, which we'll speak to in more detail in a moment, we really wanted to encourage clinicians to use a common language and understanding of the presence and degree of frailty, and to impart that standard language and knowledge to patients and caregivers as well. So we really wanted to choose a tool that will help move that forward, the language of frailty. And certainly the Frailty Index presents challenges in regards to that because it isn't itself associated with a language or vocabulary related to the frailty degree, but it is also not easily available in many of the clinical areas where we're working, because we don't have one single provincial EMR from which to draw. The Freed Frailty Phenotype, which has sort of 5 criteria, you need 3 of 5 to be frail, also requires healthcare providers to measure many things that they perhaps would not measure as part of their usual clinical care. So we decided on the clinical frailty scale that was developed by Ken Rockwood and has been validated in multiple data sets across the country and across the world. The challenge that, of course, we had encountered when we started to think about this was that there isn't enough guidance in terms of the clinical frailty scale itself, in terms of a standard of how clinicians or healthcare providers would actually apply the score. And that's where the FACT methodology was developed. So FACT stands for Frailty Assessment for Care Planning Tool, and it's a methodology for assigning a clinical frailty scale level using a more rigorous methodology. And again, the aim here was to really move the measurement of frailty out of the realm of the physician, out of the realm of geriatric medicine, to be used by non-experts in frailty and non-geriatricians. So that's the reason for including a little bit more rigor around the methodology, including the use of validated cognitive screens, the mini-cog and the brief cognitive rating scale, as well as the reliance on a collateral historian to ensure optimal accuracy of the information. And there's also been a bit of compression of some of the levels of the scale to make it a little bit more easily implemented in areas of care, particularly in acute care. This is just a screenshot of the FACT tool in the version that it's used in some of the outpatient settings in acute care, but we're going to talk about the details of this in primary care in more detail. So as you'll see along the left-hand side, we have the clinical frailty score levels as well as the descriptors, so vulnerable, mild, moderate, severe, and very severe frailty. But this scale actually allows clinicians to break down the frailty into the 4 common domains that tend to drive it, and that is deficits in mobility, social issues, deficits of function or cognition. So not only will we detect whether frailty is present, we'll know how frail a person is and whether their frailty is being driven by a particular domain. This is particularly important where interventions might be proposed to address a specific domain. For example, a person with aortic stenosis who's having problems with their mobility due to shortness of breath may benefit from an intervention to repair their aortic stenosis, but in that case we'd want to know whether there are other domains of frailty that are also prevalent, so that we'd recognize the degree to which we could expect their function or overall frailty to improve with that intervention. This is a slide just showing a screenshot of some of the logic that's used for the cognitive screen, and although the words may be quite small on the screen that you're looking at, you may recognize it as a compilation of the mini-cog at the top, and for those having difficulty with the mini-cog, we go on to the memory axis of the brief cognitive rating scale. For those individuals in whom cognition is normal, this would be a very brief tool indeed. You would just do the 3-word recall, have them draw a clock, and when they recall the 3 words afterwards, that would be the end of the cognitive screen, and you could score them accordingly. So I'm going to hand it over now to, I believe, to Tara to describe the components in primary care.
So it's actually Ashley who it's turned over here. I'm just waiting for the slides to come up. And I'm actually not able to see my slides. I'm not sure if somebody's able to.
I can keep them up on my computer if that's helpful for you, Ashley.
Yeah, why don't we do that, because it's not coming up on my screen here. So I'm just going to speak to the first slide of the statement of problem in primary health care. So thank you, Paige, for providing that overview of frailty and the tools. It's always, there's so much content to get in such a short amount of time, so I appreciate the complexities of frailty. And when we begin to discuss the frailty and interventions within the health system, I think it's important to acknowledge that the current system is really resulting in an output that's poor patient and poor provider experience of talking about frailty and intervening with frailty. So, primary care providers are experiencing an increased prevalence of frailty and individuals with frailty in their practice. And individuals in the community don't know that they're frail. And when they come into a practice, clinicians don't always know what to do when they've identified that somebody is frail. So once we acknowledge that and layer on top the complexities of an often siloed healthcare system in which frail individuals are characterized by multiple care transitions, from a primary care perspective, the clinical knowledge of frailty might not be translating to the patient, and also in a cross-system coordinated way. And from a patient perspective, they often don't understand the prognosis of frailty and how that stage of frailty can really be used in the goals of care for decision making. So really this is a slide to really capture that we're aligning expectations as well as clinician expectations with the clinical significance of frailty, and it really is more than just applying this holistic approach of care, and as Paige mentioned earlier, we're really moving that dialogue from comfort to cure, and that may mean that once we better understand frailty and talking about it in a primary care setting, it opens up a host of conversations and dialogues, which is not simple within the primary healthcare system. I think everyone on the phone can appreciate that. So within this is the next slide. So the Nova Scotia Health Authority frailty strategy was really developed to address the need for a coordinated cross-system approach. So ultimately the strategy is aimed at enabling the person experiencing frailty, and this is the patient, the families, the caregivers, to live as optimally as possible. So a few things that jump out within this strategy that are really pertinent to the purpose of this presentation is building a culture in which frailty is recognized and understood, ensuring that the person experiencing frailty are supported through an ongoing dialogue, so ongoing through the system, and the care experience is coordinated, and also the use of IT to identify and to improve care delivery of frail persons. And all of this is always aligned with the frailty-focused initiatives across sectors. So the Frailty Portal was really developed as a tool or enabler to support the frailty strategy. So the next slide you'll see is just a screenshot of the entry into the Frailty Portal. And the portal was a partnership between the primary health care at the Department of Family Practice and the PATH Clinic within the central zone of Nova Scotia Health Authority. And the next slide, really what we're talking about when we're discussing the Frailty Portal is a web-based tool. And this is used to screen and identify frail patients, engage patients, families, and caregivers into the care of frailty, enhancing the referrals and ensure that there's a coordinated care approach, again, across sectors. And it's really assisting in the transition of care. Again, you know, anybody that was at the conference this weekend and anybody that's spoken to Paige knows that this is a group that is identified and characterized by multiple transitions of care. So the Frailty Portal, again, to be a tool to support them through the multiple care transitions. And this is to be used as a mechanism to ensure that we're using evidence-based care guidelines and utilizing best practice. So from an operational perspective, to get access to the portal, it requires Nova Scotia Health Authority credentials, so login and password. It would be an email to go to one of our software developers. All of this being that we really need to make sure that we are protecting the patient's privacy is critical to this. Patients are searched within the portal from their health card number or their name and date of birth. So within the portal is the mini-cog and the fact tool, as Paige mentioned earlier, which are used for the assessment. And the care guidelines and goals and resources were provided as an output. So once an individual has been identified and staged in their level of frailty, it provided the primary care physician or nurse practitioner an opportunity to walk through some of the next steps and some guidance for care planning and coordinated treatment. So this is just a quick introduction for the research that Tara will be going into in more detail. So evaluating the portal, the phase 1 was looking at 11 primary care providers, both family physicians and nurse practitioners. So overall there was 116 assessments that were complete. And what we see there is most of the patients that were assessed really fell into that vulnerable, moderately stage of frailty. So I'm going to turn it over to Tara to give a little bit more of an overview about the actual research that was completed.
Thank you, Ashley, and Paige, for that wonderful overview of not only what we had developed within the health authority, but coming from really what we had recognized at a provincial level, the importance of addressing an important problem, but also from the health authority perspective and specifically within primary health care. So recognizing that there was an opportunity to put the evidence lens, the TVN, the CFN opportunity came at a very timely point for us. So we decided to look at the introduction of technology as a way of bringing a level of integration, coordination to the management of the frail population, but at the same time to also engage our providers in a different way. It's almost an education and awareness raising tool. And at the end of the day, being able to engage patients and caregivers in the process as well. So We recognized early on that being a one-year study, we would probably not get to very, grand outcomes. But what we wanted to explore was really the being an implementation study, whether we could look at the feasibility. So recognizing that, of course, the research design also, had to support that process. So we did go with the consolidated framework for implementation research, looking at specifically what factors might support or influence the implementation, leading to the feasibility of using the Frailty Portal as a way to support all the broader outcomes that we want to achieve and the long-term outcomes. And again, going at the level of the engagement process for the patients, caregivers, and primary care providers. And we were also hoping to then look at the core components that would be essential to scale up the opportunity. What was very neat for us, although given the one-year timeline, we had established some connection, collaboration with Frail Health in BC, and they were immediately agreeing to partner with us to look at, how this implementation study would actually unfold, and querying the relevance and importance at in their jurisdiction. So we were really fortunate that all that aligned within this time frame. If we can go to the next slide, please. Oh, that would be me. So within Nova Scotia, as we said, because it's a feasibility study, we wanted to ensure that we had a good range of settings to test this. First of all, we recognize that it's a technology implementation. There are many considerations that come in place. It depends on whether it is accessibility to get into the web-based portal. Are they solo providers? Are they in a team-based practice? And then the fee codes, and then the payment strategy. All of those had to be examined because it just had to become a sustainable plan for us. So again, given the time frame, uptake is always a challenge. So we recognize that going in. And
welcome to Desjardins Card Service.
So we did try our best to engage the physicians and recruit as many, and to give the diversity. So that's what you will see in this slide. And we also wanted to engage patients. So we did request the providers that did participate in the study to then recruit patients in their own practice, so that they can then be engaged in feedback process as well. So it was a mixed methods design. What we did do is focus on a lot of process measures, such as uptake of the use of the portal, and number of patients recruited, number of providers recruited, diversity in settings. But also we wanted to look at the experience of using some other things, because we also had the FACT tool that was embedded. So did that get to what we were hoping to get at? Did the technology support that? Were the providers satisfied? Some of our outcomes were all focusing on that. So you will see the type of patients that we were able to recruit and how many care plans were completed using the portal. And we also used within the SAFER, the Consolidated Framework for Implementation Research, semi-structured interviews to engage providers in a conversation, because at the end of the day, we did realize that we wanted to have that feedback. We had done a bit of the pilot process in 2014, and here it was going to really focus on, can we implement this? So if you see the barriers that were identified by the providers, I would say it's not very surprising. I'm sure across all jurisdictions we'd agree that this is probably what will come up, but the extent or the degree to which some of these problems may be more magnified might depend on the infrastructure in different provinces. And for us in Nova Scotia, it was an exploration of, what does it really mean when we say the clinic workflow has to allow this? What does it mean when there are technical issues or technology challenges? Because that really depends on the IT infrastructure and all of those. So those were identified, and I'm sure all of you will agree that those seem to make sense. And we also wanted to look at, are people overall in agreement? Are we arriving at a consensus that this problem has to be dealt with, and this is one way of doing it? And overall, there was a high level of agreement among the people that participated that this is important. And people did identify, as it's listed here, what were the things that would support that, or why it was important. And some of the things that we recognize as challenges are also not very surprising. Again, the fact that the technology has to be integrated is probably one of the biggest feedback we got. In this situation, providers had to actually go to a web-based portal which is outside of their EMRs to be able to access the portal. So that was a very strong feedback to us, that it took time, and so it was not very practical in a clinic workflow to be able to do that. Again, the fee codes is an ongoing conversation for us, and I'm sure it is not unlike what other people may be facing. And then getting the collateral history from the family members was another piece that we did hear back, and all of these things that are listed here will become part of the consideration. The top on the list being EMR is being a very strong consideration for us, that the portal, the web-based portal, should integrate into the EMR so people don't have to log in to a separate thing. The other big thing that we did here was about access to community resources, and we knew that, you know, you change one thing, you'll have to look at the bigger picture and integrate everything that's essential. So providers did say that while it was very helpful to be able to understand what to do given the level of frailty that was recognized based on the screening, what community resources are then supportive of the provider being able to offer timely care to the patients was another bigger conversation for us, and that's ongoing through the frailty strategy. So people who have been aligned, we had a broad team of people engaged, including researchers that are not part of the conversation today, but it was a full team effort. So that was critical as well, just engaging the right people to participate in this work. So I will hand it over to Ashley, and we have published our research, including our protocol paper, and the results paper is will be out pretty soon. So if people have questions, they can go to the paper. I'll be sharing that with the organizers. Ashley, over to you.
Great, thank you, Tara. So I'm sure as many people can appreciate, when we do research or trial projects, there's always lots and lots of lessons learned, and we certainly fall into that category when we're talking about the Frailty Portal within Central Zone of Nova Scotia. So many of the challenges that Tara recently explained outside of the EMR and access to the portal. So in the future, we're really looking at embedding some of the flexibility of the portal to adjust to meet the needs of the variety of clinical settings. So not just talking about family physicians' offices, but also what would something like a Frailty Portal look like in emergency or inpatient units, in acute care. We're also exploring how we can further leverage existing IT systems to find efficiencies for this tool. So where can we pull information from the EMR to pre-populate particular fields in the Frailty Portal, such as demographics, for example, and again, tie all the information to the EMR or to IT systems so that there's this automatic facilitated conversation from an information technology perspective to facilitate that conversation across sectors to really break down some of those silos that we spoke to earlier. And we're really, continuing to work to align the Frailty Portal with the Frailty strategy within primary health care, as well as many other areas in Nova Scotia Health Authority. So I'm going to turn it over to Paige.
So thank you, Ashley and Tara. I think one of the learnings, as Ashley spoke to a bit in the last slide, was just that, that whereas these patients are characterized by the fact that they have multiple transitions from one area of care to another, including between primary care and acute care, the interest in using this technology and platform outside of primary care to assist in primary care has been a key interest. So, for example, not only being able to access the person's baseline frailty status when they arrive in the emergency department, but perhaps after an acute stay, being able to update the portal in such a way that the care planning items and care planning tools can be updated for the primary care physician. We also have a lot of interest in some ambulatory care settings within the tertiary care hospital here. So for example, social workers or occupational therapists who regularly work with frail older adults are often saying, well, I'd really like to be able to not only access the portal, but assist with enrolling patients into the portal. So I think that provides us with an increased opportunity for longitudinal information, and it's really critically important in terms of the portal's effectiveness for clinical care that it reflect not only that person's baseline, but also be updated to reflect a new baseline after any changes in health or an acute health crisis. So I think some of the challenges related to that we're aiming to address through the broader strategy for frailty within the Nova Scotia Health Authority is just, again, growing the awareness and common language of what frailty is, what it means for care, what it means for care providers in various areas of care, but also really working closely with IT to make sure that this web-based platform is talking with and supporting some of the existing technologies. And here in Nova Scotia, we're aiming to move to a one patient, one record format, and that will have implications for how the portal speaks to that record and to what degree it's sort of integrated in with that record. So I think what I'll do is, given the time, we'll turn it over to questions. And I think perhaps, Carol, as you'd suggested before the webinar began, that perhaps I could aim to field the questions and direct them to Tara and Ashley as needed.
Yes, that sounds like a good plan. So we do have quite a few good questions that have already come up. And the first question is from Colleen Maxwell, and she's actually directing the question to you, Paige. She said, you stated that frailty is the single most important prognostic factor across population setting and interventions. Yet, in many studies, the addition of frailty provides only modest added value to prognostic risk scores. She's saying we need to remember this. Yes, frailty consistently predicts bad things happening, but often the added value is modest over and above other well-established risk measures.
Great. So thank you for that question and comment. And I think you're right in that frailty is one of many different parameters that can assist with prognostication. I think what I was referring to in terms of that slide is that, again, when you look at the literature, regardless of whether you're looking at patients who are receiving care in China or North America, whether they're undergoing surgery, dialysis, or whether they're in long-term care, the prognostic significance of frailty, has emerged in various studies as important. And again, I also spoke to the notion that there are multiple different tools for measuring frailty, and I think there's also conceptual disagreement within the community as to what degree frailty may be reversible. And so I think that, we need to take into account the language that we're using to measure frailty, the conceptual basis that is the foundation for the tool that's been used, and also the degree to which the tool is being used accurately and appropriately, because I've certainly seen many patients in my practice who were believed to be frail based on one or more assessments that actually weren't frail when a more detailed assessment was done, or were perhaps less frail than was originally thought. Even within our health zone, there are many providers who don't consider frailty to be a sort of baseline characteristic, that they say, well, when someone's in the emergency department, they're more frail than their usual frailty, when, again, I think the language that we're trying to move towards in terms of a concept is that this is a baseline state variable that may change after an acute health crisis, but shouldn't be measured based on current function in the throes of an acute health crisis. So I think we're getting better at choosing tools. I think we're getting better at understanding the limitations in terms of where we apply those tools and what the considerations need to be. But I think moving forward, we will see more and more robustness of frailty as a predictor for these health outcomes. And I'll just invite Tara or Ashley to turn on their mics if they have any further comments about that.
Ashley
Paige,
here. No, I think you answered that well, Paige.
Likewise for me. Thank you.
Okay. So we have two questions that kind of are related. So I'll ask the first one because I think you've, Paige, that was the end of that question. You have no more to add?
Nope, nope.
Okay, perfect then. Here's the question. It seems that FACT has a number of advantages versus simply using the clinical frailty scale. Should FACT be the primary standard tool to assess frailty? And if so, why do you think others continue to use the clinical frailty scale and not FACT?
Okay, so a couple of things there. I think, again, the clinical frailty scale has been used in various care settings successfully. The challenge with the clinical frailty scale is that it relies on Gestalt clinician judgment, and we know that issues with cognition are often missed, including baseline dementia, but also delirium. And that has an impact on how we understand baseline frailty. And we also know that oftentimes patients can provide a history of their own day-to-day function at home that may not reflect, a more objective version of their day-to-day function at home. And that was, as I said before, one of the impetus for developing this tool. I think that, the FACT has been modified or adapted, I should say, to various care settings. So the way that it's administered, for example, in the emergency department versus the way that it's administered in a outpatient clinic in tertiary care, or the way it's administered in primary care, are all slightly modified, but rely on the common features of having an objective cognitive assessment, understanding whether a person's cognition on that day represents their baseline or not, having a history from a collateral source to further inform the function. And so I do think that it offers the ability to sort of overcome some of the limitations of the clinical frailty scale. And certainly when we've compared it directly to clinician judgment, it's significantly better at picking up on frailty when it's present. And we're using the frailty index as the gold standard for that. So I think there's lots of opportunities to expand that methodology and even adapt it for other care settings. So I do hope to see it expand.
Okay. Anybody else have anything to add to that? No? So this is kind of part two to that question is Kieran Quinn had said that she loves the FACT tool, but has it been validated for use in non-geriatricians, and what are some of its performance characteristics? Inner rater, reliability, etc.
Yeah, so it has been validated in non-geriatric settings, and in fact we never began by aiming to validate it within the geriatric medicine milieu. We designed the tool to be used by non-experts outside of geriatric medicine. So there is a publication regarding the FACT in an outpatient clinic setting that's been submitted for publication, and we're just waiting to hear back on that. But if you want further information in terms of some of the characteristics of the tool, you could perhaps email me and we could go through those in more detail.
Okay. Here's another good question, and I'm not sure that you addressed this yet, but maybe it's your next research plan or knowledge translation. Do you have plans to incorporate ACP or an end-of-life module to the Frailty Portal so that the FACT triggers ACP discussions?
I feel like I'm doing all the talking here, so I'll invite Ashley or Tara if they want to comment. That would be great, or I can comment as well.
So Ashley here, I can speak from an operational perspective. So it is interesting that from a research perspective, I don't have the answer, but from an operational perspective, if we're moving towards a system where we're really working at breaking down those silos, for me and the seat that I hold as part of this conversation, this dialogue, is how can we equip all care providers. So right now we're really focused on physicians, but when specific to the Frailty Portal, there's very little that is physician specific, meaning that there's many aspects of the care planning that can go to advanced care paramedics, that can go to nurses in long-term care, that can go to physio, dietitian, because we're talking about a holistic approach to the client experience through the system. So I offer that in terms of the potential of the Frailty Portal when we talk about cross systems, because the way that we're thinking and the way that we're trying to develop this as a tool within Nova Scotia is to break down some of those barriers, so that once an individual has been identified as frail, assigned their level of frailty based on the assessment, whatever that assessment tool may end up being, the care planning would follow the appropriateness based on the client's needs. So from an operational perspective, that's what I would offer. Tara and Paige, I would hand it back to you if there was any specific research that jumped out to you with regards to that.
I just wanted, this Tara here, I just wanted to speak, and I think Ashley, you covered it really well. And when we, considered this project, we did put the CFIR framework on it, the consolidated framework, recognizing that we were going to understand about the factors that influence the implementation. And definitely this was one of the feedback we've already received, to suggest that we should be looking at it in terms broader than, if the expanse of where the influence will go and what will improve the care experience for the patients and the caregivers. So this is next on our radar as to what are the other factors that should be embedded into the process. So great question, and yes, definitely it is the next step for us, and we'll definitely move into a research mode with that as well.
So I was just going to add to that a little bit as well. So just to break things down a little bit into care planning versus advanced care planning. So in terms of care planning, each frailty level is itself associated with a list of visit goals for the primary care physician, and they're able to chart, when they've started and or completed each of those. And they are very much targeted towards assisting with the care plan for now and in the future, in terms of developing an opinion around capacity for decision making, involving second decision makers, discussing the importance of frailty for upcoming elective procedures, for example. And as it pertains to advanced care planning, I think one of the main advantages of the portal in this regard is that it would integrate a standard cognitive assessment into the process. And if you look at some of the provincial programs that have been developed for advanced care planning, I'm not aware of any of them that actually include an assessment of the person's cognition to help inform who the stakeholders would be in terms of discussing an advanced care plan. So I think that there's an opportunity there from the perspective of the portal to ensure that if there's significant cognitive impairment detected, that we enlarge the circle of care to include the person's caregiver in discussions around how future health crises might be managed.
A good discussion, and there is a lot of advanced care planning in our population going on right now. And we did have a comment from Marilyn Clayton. She says, we in hospice palliative care hope that the ACP discussion will happen way before the end of life. We are in the long-term care looking for a great tool for assessing frailty. So, and she has a further question here or comment. Advanced care planning can only be done by the cognitively well individual. I think what you were alluding to, Paige.
Yeah, I quite agree. And I think that, even for the cognitively well individual, it's been my practice that others should be involved in that conversation, that are going to be acting on any of the plans that are made, so that they're aware of the discussion and been part of the discussion, not just called upon during a health crisis, for the first time coming into the situation blind. Thank you, Marilyn, for that comment.
Okay. And, as you were speaking on something else, another question came in, and it related to something you said just a few minutes before we started the advanced care discussion. Could you speak a bit more to the care guidelines, goals, and resources output that result from the FACT assessment? What does it look like? Does it lead, and I think this is one of the most important questions, does it lead to direct referrals to the community services? And was this explored in the feasibility study?
So Ashley's been working on that quite a bit. Ashley, do you want to speak to that?
Of course, yeah. So one of the biggest things that we noticed from this research was that when we started talking to primary care providers about what did you think of the Frailty Portal, they liked most of it. They really did. The thing that I think they were challenged with was exactly that, the output. The previous iteration really created a list of everything for the primary care physician or nurse practitioner to do as a result of the frailty stage. And I think there was the intent that it would provide them that really robust narrative about how to have that conversation, and upon reflection and speaking to physicians and learning from this research, we knew that we had to really take the time to map out some of those conversations for them. So what we're working on right now within the primary health setting with physicians and nurse practitioners and re-engaging in community is a much simpler, really a template to say, here are all the goals that we previously provided you in the last iteration of the portal, but what we're going to do is break these down to say, your visit 1 should be about 15 minutes, and here's the things that you can get done in 15 minutes, appreciating the clinical setting that they'd be accessing for primary health care and the limitations of that system. The luxury of having somebody in your office for an hour visit to talk about frailty is just not in that system. So we needed to go into that with a healthy appreciation. Likewise, when we're doing some of this mapping in the inpatient units, we're also having that dialogue of what is the what now? How do we enable practitioners and clinicians to use this to change and influence their patients and their families and the caregivers in that experience? So that is absolutely something that we are working quite a bit on at this phase, and have just begin to put that out to a group of family physicians to pilot, and then hoping that that can gain some steam in the near future.
I was just going to speak to one more issue around that, and that is that while we want to ensure that patients who are seen have access and are matched up with supports and services that are available and applicable to their particular level of frailty, the other main sort of vision for the frailty strategy is to really streamline the care of patients and to aim to, over time and as frailty progresses, really demedicalize the care experience. So we don't want to end up in a situation where we're just generating referrals to all sorts of various specialists and different types of healthcare providers. We want to really keep our eye on the ball in terms of this being a generalist sort of overview of a person's health and figuring out which of these things are really applicable to you, which of them are really going to help move you forward in your current stage of frailty, instead of sort of burdening people with additional sort of referrals and assessments that might not change the ultimate outcome.
Okay. I'm going to take this to a little bit of a different spin, and I think this is a result of the discussion at the conference, at the Health Info Way discussion at our CFN conference that was looking at security and access of information. So it was mentioned that access to the Frailty Portal was secured and required a Nova Scotia Health Authority credentials. This is obviously a good thing to protect patients' privacy, but will there be an effort to let patients and their close family caregivers access their own healthcare records?
Oh, this is Tara here. I can certainly speak to that, and what a great question. So I just want to take a step back there in the conversation. So early on when we had Frail Health agree to participate with us, one of the things that did become a barrier was the very same thing, the security of being able to bring another province on board, a web-based portal that was not secure to hold their information, and that's the reason they couldn't go to the full extent of using and testing and applying it in practice, whereas we had completed all those protocols, we were able to do it. So that was one thing that we recognized upfront. The next thing is really, what does it mean to have this portal? It's not just, if we believe that patients and caregivers are equal participants in this conversation, then we really have to move to that next extent of how do we give access to patients and caregivers to their own information. So that is where Nova Scotia is building a strategy at a provincial level, and we're still early in the conversation, but we are definitely keeping that within our sight to say, what does it mean for patients to access this information. So the Frailty Portal is becoming part of the EMR strategy conversation, as is the patient access to the portal and broader to the EMR. And I think many of you will have heard of the My Health NS, which is the patient portal access to EMR. So we are definitely aligned with that conversation of how do we make this accessible to patients and caregivers.
Okay. Does anybody have anything to add to that? I know it was a great conversation at our conference, and I know we're not there yet, but it keeps coming up, the same question. Okay, I'll move on to the next question is from Amini Ali from the UK, it looks like. And what the question is what is the clinical impact to identify frailty using this tool from a perspective of outcomes like length of stay, mortality? In other words, here in UK, they do the same assessment called frail safe, and I didn't see any in a clinical impact. Is it just a ticker on the patient's file?
So I think that certainly this study will, or this Frailty Portal will go some of the way to figuring out to what degree primary care physicians are acting on the result of the assessment, and then that could be linked to issues around healthcare utilization, lengths of stay, and outcomes. But really, I think that, you know, the assessment of frailty is only the first step. Clinicians in primary care and likewise in acute care and continuing care need a lot of education and training about how that result should impact what you know, their approach to care is. And again, this is where the frailty strategy comes in terms of providing tools for and resources for care planning and making sure that we're consistent in terms of the so what. And the idea is that over time, as frailty becomes more routinely measured in each of these areas, that we will be able to link that to health outcomes. But currently there are no, or at least there, other than pockets here and there are no routine measurements of frailty that are done throughout the Nova Scotia Health Authority. So it's really difficult to measure that impact until we're up and running a bit with clinicians doing this routinely in various areas of care.
Okay. So I see it's coming on 12:55, so I think that concludes the questions for today. So again, thank you, Paige, Ashley, and Tara for the excellent presentation and a great discussion we've had today. And thanks to everyone for coming on today and asking some questions that really started a good discussion, which will continue into the near future. So please watch, as you see on our screen right now, we have the webinars that are currently been planned, and we'll add a few more in the next week or two. So please watch our website for these future webinars to register. So again, thank you to everyone. That ends our webinar today. So have a good day and hope you join us in our next webinar. Take care.